Hello friend, this is a case of diagnostic laparoscopy, tubal patency test and hysteroscopy, and this patient is an infertility patient. So, we will do diagnostic laparoscopy, and for tubal patency test we are going to use the ICG and different mode of ICG like E and B mode, contrast mode we will see. So, this is the two Ellis forceps applied on the either side of the umbilicus, and after that this is a stab wound given over the inferior crease of umbilicus, and then you will take a Veress needle and introduce the Veress needle perpendicular to abdominal wall, but oblique to the body. And then here this Ellis forceps is removed and irrigation suction and hanging drop test will be performed. Now the Veress insufflation is started and we are keeping preset pressure 15. Actual pressure is slowly reaching to 16 and flow rate is 1 liter per minute. And we can see homogeneous distension is started. After that we will remove the Veress needle, enlarge the incision to 11 mm. The smiling incision, and then this is the first optical port which is introduced, that is port for telescope. Now second port is in between the external superior iliac spine and umbilicus, 1/3 from the ACIS and 2/3 from the umbilicus. That is just like a McBurney point which we use for right side for the appendectomy. It is the same McBurney point of the left side. A line drawing anterior superior iliac spine and umbilicus, 1/3 from anterior superior iliac spine and 2/3 from the umbilicus. Because diagnostic laparoscopy we will do only 2 ports, so third port is not required. So only 2 port is enough. We will do the ovarian drilling on this case also because patient has PCOD. So we can see this is the bladder here in front, the horizontal line of the bladder. All the small bowel is lifted up. This is the small intestine. This is the sacral promontory here in front. You can see this is the sacral promontory, and here this is the common iliac vessel. This is the ureter. Peristalsis of ureter you can see clearly. This is ureter, and this is the sacral promontory here, whitish pearly white color you can see. And on the right side there is anterior longitudinal ligament. This is the sigmoid colon in front. This is the mesenteric vessel of sigmoid, and in the midline you can see median sacral vessel which is over the sacral promontory. When you have to do sacrocolpopexy, you have to lift the peritoneum like that, and then you can cut lateral to the rectum and medial to the ureter for sacrohistopexy or sacrocolpopexy. So, once you will stretch it and then cut, ureter will not be damaged. So, this is the ureter. This is external iliac artery, external iliac vein. This is the IP ligament, and this is the triangle of Doom. Here is the GFN, genital branch of genitofemoral nerve, and this is the triangle of pain, and this is the trapezoid of disaster. So, if you have to see the ovary, you will hang up the IP ligament and ovary will come up. So, this is the ovary, this is a polycystic ovary according to ultrasound. So, we will do drilling later once you will check the tubal patency test. This is the left ovary and left fimbrial end of the tube, that is also lifted up. And this is the uterus, this is the fimbrial end of the tube either side, and this is the cul-de-sac. So, this is just a simple diagnostic. Fortunately, there is no endometriosis, there is no any pelvic inflammatory disease, there is no any problem. This is the median umbilical ligament in the middle, and these are the two medial umbilical ligament. This is right, this is left medial umbilical ligament, and here is the landmark of the inferior epigastric vessel, which is down starting from the deep ring, and this is inferior epigastric vessel, that is the lateral umbilical ligament. So, this is the anterior wall anatomy, and this is the left side. This is the left side of the deep ring, left side of triangle of Doom, left side of triangle of pain, and this is inferior epigastric vessel of the left side. This is the UV fold, and this all area belongs to bladder in between two medial. Now, this is the cervix, and here we are entering into the uterine cavity with the hysteroscope. So, this is the fundus of the uterus, and then this is the posterior wall, and you will keep the CCD correct and turn the light cable towards the left side, towards your left, then you will see right, and this is right, your right is left ostia. So, we can see this ostia, and this is open, you can see little dilated, and that is very good option. We can see wheel of the fluid also, that means this is open, and this is the right ostia, your left is patient right. So, this is the right ostia, that is also fine. There is no any polyp in the uterus of the patient, posterior wall is fine, this is anterior wall, that is also good, fundus is also good, and absolutely normal anatomy. This is the posterior wall of the uterus. This is proliferative phase, that is why you can see white dot, and the thin vessels are there. This is again the left ostia. This is posterior wall, and this is the right ostia. So, hysteroscopy is also performed, and by hysteroscopy it looks like open tube, because fluid is entering in both the ostia. So, this is posterior wall, this is internal os, here is the internal os, and this is cervical canal. This is posterior wall of the cervical canal, and if you turn the light cable down, you can see the interior wall of cervical canal. And now slowly telescope is withdrawn, this is external os, and we are out. So, this is done. After that, we are injecting the ICG by HSG cannula, and you can see this fluid. Right now, you will not see anything, but as soon as you will press the button of the ICG mode, then ICG will start visible. And you can see this is the fimbria, this is the right fimbria, and this is the left fimbria. This is the left fimbria, and you can see the green color is coming out, and then this is the ICG mode. And you can see entire ICG is leaking from either side, and entire ureter also will, entire tube also will get completely stained. And a SPI gain of the ICG you can adjust. So, it is decreasing the SPI gain, and then you can bring the telescope nearer to the tube, and the lumen of the tube you can inspect by the ICG for any kinking, for any patch of the tuberculosis, or for any other filling defect. So, one of the biggest advantage of ICG is that entire lumen also can be examined either side, and for that you have to decrease the SPI gain, and then you can look for that. After that, you can change the mode for the contrast mode. Right now this is the overlay mode. In overlay mode, ICG will be showing green and surrounding will be colored. Now this is normal mode, and now this is contrast mode. In contrast mode, ICG will look white and surrounding structure will look black. And if you go near the tube, you can see white line of the ICG line inside the lumen of the tube will be clearly visible, and fimbria also white color will be visible. So, this is contrast mode. In contrast mode, you can see the ciliary linings also can be visualized, and here also a SPI intensity of the contrast mode you can increase. Now, this is normal mode. This is again contrast mode, and you can see this is the CSF mode, and then ENV mode, and then this is overlay mode. So, in ENV mode, surrounding will be gray and the fluid will be green. So, this is very good to do diagnostic laparoscopy. Now, we are sucking all the fluid out, and we will suck it out, and we will just irrigate little bit and again suck it. After that, this is the just above the pubic symphysis, we are putting one striker mini alligator, and this striker mini alligator will hold the ovarian ligament, and then we will do the ovarian drilling with the PCOD needle. So, this is PCOD needle which is doing the ovarian drilling. Advantage of this is that it does not burn the cortex, and it go only 4 millimeter deeper, and it need only 40-watt current. So, it does not burn the outer cortex, and it does not do the adhesion. So, many people they use hook. Hook is not a good instrument to do ovarian drilling. It is risky. It create more adhesion, and it is hook is L-shaped. So, due to this L shape, it is doing burning of the cortex wall. So, that is why you should not use it, and you should keep on doing the PCOD needle. That is the best instrument to do the drilling. So, this is drilling is performed on the right side. After that, we will do drilling of the left side, and you should must be careful that if you are using the striker mini alligator, then catch only the ovarian ligament. Don't hold fallopian tube any time, otherwise a stricture will happen. And now this is again drilling started. First you should do posterior wall, and once you have lifted the ovary, then press the needle. Here by default needle is always in. Once you will press by the thumb, then only needle comes out. So, first you can adjust the ovary over the tip and then press the needle, so that it will not prick at wrong place. Wherever you want, it will prick only at that place. So, this will help you very controlled drilling, and it does not go more than 4 millimeter. So, 4 pole, 4 to 8 pole you can puncture, 40-watt current you should use. 4 millimeter deeper it should go. 4 seconds you should press the monopolar, and 4 months it takes for hormonal disbalance to get corrected. So it is done, and ovarian drilling is also over. After that we will do some local lavage. So some fluid will be irrigated and sucked, and at the end we will leave some fluid inside so that it will not do the adhesion with this ovary and fimbrial end of the tube. So after suction irrigation, you will suck it, and then some fluid you will leave it. So thank you very much for watching this video. Have a nice day.